regarding myself, I am the chairman of the renal sciences of the MASH group of hospitals, and I also visit here at Punjabi Bagh. I've joined here only 2 months back, and but I have been in practice for the last 28 years here in Delhi. I was associated with the starting of the Max group. I was one of the first 4 doctors which joined Max when they started, and for 15 years I was with Max, and at the same time I was with Modi Hospital and Sanjeevan Hospital, and I was covering practically the entire NCR area. I've been responsible for starting almost urology in 20 centers in the Delhi NCR, and I've worked for 3 years in Fortis Gurgaon when they started, and for an year in between in PSRI, and till recently I was at Batra Hospital for the last 10 years, and now I'm here at this thing. So, as you are all aware, and in your practice, a large percent of your patient load regarding your urology pertains to stone disease, and it is very commonplace now that all of you are well equipped to advise patients that the kind of treatments that are available and required. And for kidney stones, it has now been well established that the treatment for large kidney stones would be PCNL surgery, and today I am here to talk about a further refinement, because at the focus of any treatment should always be the patient. And today also, even a commonplace surgery like hernia, today also it continues to be refined more and more, and more treatments are brought up, because no procedure can be said to have the last word in entirety or in definitive. There will always be improvements, and something or the other will be added for the patient benefit. So PCNL we have been doing for about half a century now, and with miniaturization, because at times people felt that the 1 centimeter holes were also big. So instruments started getting miniaturized. We had the mini perk, micro perk, super mini perk, and we came down in to a very small size of instruments with that. And over a period of time, it came down that the anesthesia requirements moved from general anesthesia to regional anesthesia, spinal anesthesia, for patients who need a staged procedure, who had large stones in both kidneys, if they needed it. If they would require multiple punctures, you could even leave a epidural catheter for 2 days and do the second stage after 2 days. And even local anesthesia for patients who were unfit for any kind of anesthesia, who had poor cardiac reserve and large set of comorbidities. And what was being done was that the patient cystoscopy was done. We passed the ureteric catheter to the side of the kidney and turned the patient prone, and punctured the calyx, which was the calyx of concern, and fragmented the stones and removed it after leaving a stent, a nephrostomy tube, and a Foley's catheter. So all this was being done, but then came the problem, because more and more moribund patients required the procedure. So what was required was that a procedure would be not challenging for the anesthetist as well, which would be good in terms of the outcomes. So in 1987, this procedure was introduced. For a long time it did not come into practice because of teams. But the reason why it came to be about was that the anesthetist said that in prone position, a lot of times they were facing problems for patients who were morbidly obese. To turn them prone and to maintain their ventilation became a problem, and patients at times could not lie down prone. The patients who had spinal deformities, their ventilation was poor in prone position, and also whenever hemodynamic alterations occurred, as they do occur in quite a few patients, so there was difficulty in managing them. So this gave birth to this supine PCNLs, that patient's procedure could be done in the supine position itself. And at times we have seen that if a procedure required to be abandoned at a particular stage, because the stone, which was Staghorn stones, as you all know, they would contain the bacteria within the stone. There may be an element of sepsis. You need to stage the procedure, wait. So it's very difficult to turn the patient immediately back from prone to supine in such a case when there is a problem. But with this supine PCNL, that is not the case, because the patient is already in supine position. And as you can see out here, that we stick to a very basic landmarks that are there, and we remain in an area between the lower border of the 12th rib, the iliac crest, which is palpable even in the most morbidly obese patients, and we stay behind the posterior axillary line. Staying behind the posterior axillary line means that one would not breach the peritoneum adversely. So this is enough for us, and from here we can approach any calyx that we require. And because again there were further refinements so that we could do procedures along with, in this spine position, we could operate in the kidney and for upper ureteric stones at the same time in this position. So with this position we could maintain for a significant period of time, and once you keep a bag of saline under the patient, so the space that you saw in the diagram in the previous thing, this also stretches out to about 5 inches or so. Here you can see the advantage in this case is that if you see the top, we operate in a very horizontal plane, and as you can see on the image intensifier photograph, that again our tract is very straight, very close, and also it is horizontal, which means that the ergonomics, the ease of doing the procedure is very much so. And at the end, if you see in the bottommost picture, for the kind of instrument we use, that the patient has undergone all the tube has been removed, the nephroscope has been removed, and there is just a nail-sized hole that is left, which will heal on its own. Now imagine if this patient was to undergo some surgery in the prone position. It would be very difficult for the operating surgeon, for the anesthetist, for the post-operative position also, because the patient, it's very difficult for the patient to breathe and stay in the position. This patient, of course, is in general anesthesia. At times we do under spinal anesthesia also these procedures. So for patients to lie down with bolster under their abdomen, and the table in a broken position with the bend at the 12th rib. So it's difficult to maintain the position for these patients. So as we have enumerated that anesthesia is better, the operating time is shorter because the time taken to make the patient prone and set up the position is taken away. Because we are operating in the horizontal plane, the intrarenal pressures are not high, which means that the risk of sepsis is low. What happens is, when we are operating from top, our fluid that we use, it goes with a high pressure into the kidney. There is a chance of absorption, there is a chance of element of sepsis, despite whatever precautions you might take, some very few percentage also, but still there will be some element of fluid absorption and sepsis. In the supine position, as we have told you, in the modified position, we can have one person who is operating on the kidney. The assistants will pass the flexible ureteroscope, and the stones are managed both at the same time in the ureter and in this thing. For prone position, if we have stones in different calyces, we have to make different punctures in all the calyx. The punctures are usually around this size, but still they have to be made, and it extends the procedure time. It means that there is a breach of the nephrons in the kidney. But with this supine PCNL, what happens is that the assistant can bring out stones from the calyx and hand them to where the operating surgeon is operating in the kidney. The person will bring the stone in front of the instrument from the different calyx. So you don't have to make different holes in the calyces. The cons are, as you saw in the X-ray picture. Let me show you once again. That the kidney is pushed. The kidney is very mobile. So that is the only flip side to the thing. But with the practice and experience in doing these things are managed and you take them into account. Over here, as you can see, this is a very sick patient, and patient had pyonephrosis and emphysematous pyelonephritis. It is a very life-threatening infection of the kidney. So making the patient prone with the altered hemodynamics, with the patient was already on vasopressor drugs. So making the patient prone is nearly impossible, and monitoring the patient in that case. But in the supine position, as you can see, we have hit the calyx of concern and we are extracting the pus out. And we left the nephrostomy tube. Once the nephrostomy tube is inside, the infection drainage becomes that much more better for the patient. So at the end of the day, the surgery would be measured whether it does the job as well as it was supposed to do. So stone clearance rates for both the procedures are same. But what is more important is that in supine position, we are able to minimize the morbidity of the patient, the length of stay, duration of operation, and the blood transfusion, because we require it rarely in prone PCNL, but it is still lesser in supine PCNL because the multiple punctures are not required in this surgery. Obesity, as we have seen, that it is a major issue in most surgeries, and PCNL is not an exception to that. So that has to be taken into account while planning any surgery for any patient. And of course, as I said in the beginning, no surgery is perfect, but in case the patient has horseshoe kidney, so their prone PCNL is better because the calyces in the horseshoe kidney are just facing right in front for puncture. Our entry in the supine is in this plane, but in horseshoe kidney they are facing right in front. So in that condition, of course, the prone PCNL remains a better option. And to sum up this supine PCNL, it offers advantages in terms of operability and also in terms of anesthesia requirement, and is a good procedure where stone-free rates are to be seen and complications are lesser if the procedure is done in experienced hands like any other surgery. And that the anatomical approach, the bottom line still remains that the anatomical approach of course will remain depending on the surgeon's experience, the patient's preference, and the anatomic and physiological data available. But it is one more procedure in the armamentarium for us urologists. And as I said earlier, I need to reiterate that the surgery must keep the patient benefits at the center of the procedure. This does not bring about any cost to the patient because the instruments are the same. It does not, just because we are offering a procedure where we feel that the technique has been bettered for the benefit of the patient, so the charges will be more. The charges will be the same. But for our own sake and for the patient's sake, we must know that once this thing is available, we must use it as a handicraft rather than use it just for the sake of using it or for the sake of increasing the prices of an already existing procedure. So with that, I end my talk out here. If there are any questions, I would be happy to take. And I must thank all of you for being so patient in waiting for me and taking time out to listen to me. And I do hope that we will have more interactions in the future. And thank you once again.
Thank you, sir. Any question for sir? No. Thank you all doctors. I know we are too late today and lunch is ready. Please enjoy. Thank you so much.